Welcome to the Fight Cancer with Dr. Prasad podcast, your source for the latest, most reliable, and research based information about cancers and their treatments. Hello, I'm your host, Dr. Prasad Dandekar. I'm a radiation oncologist with Reliance Foundation Hospital in Mumbai. And today we are going to talk about brain tumors. Now, brain tumors is something which is very interesting topic to talk to because it creates so much of confusion in the minds of patients. And here today we have one of the best neurosurgeons that we have in Mumbai and probably in the country, Dr. Mazda Turel. Dr. Mazda Turel has a very interesting story, and as you get to know him through the podcast, you will realize how interesting his thought process is and how well he writes as well. But Dr. Mazda, if you see his profile, he has traveled all over the world, starting from Bombay to China to US, and he's been trained so extensively in neurosurgery and is a practicing neurosurgeon at Wokhar Hospital in Mumbai. He's a very good writer, and he also has extensive publications in medical journals. Thank you very much for joining us, Dr. Mazda, and sparing your time for our patients.
No, the pleasure is entirely mine. Thanks, Prasad, for having me on this wonderful initiative that you have launched to spread awareness of cancer and fight cancer, and in the hope that someday we may be able to conquer this disease. You may be out of work by the time we do it, but
well,
it might be
don't we hope that
greatest victory, right?
Yes, that would be the perfect victory for us to be out of work. Yeah. So, Mazda, I know you for a while now, and I know how passionate you are about neurosurgery. What got you into neurosurgery?
So, while it seems like it might be the standard Indian story of every son choosing the father's profession, my father, is an eminent neurosurgeon in the country. And right from childhood, we were raised listening to stories of neurosurgery. I remember the time when he used to come home from work quite late in the evenings and used to sit with a single malt and watch his operations that he performed that day. And he used to look at it with so much excitement and look at it with so much passion, and he used to make me sit with him. And I used to look at brain tumor surgeries right from a very young age, even when I was single digit in age. And it used to enamor me, and he used to tell me that if you need to become a great surgeon, you need to learn how to eat with a fork and a knife. And every single meal that we ate was compared to what tumor it could be. So I'm not ashamed to say that I was deeply influenced by him, though he actually insisted that or discouraged me from becoming a surgeon because of the cruelty of the profession, the sacrifice it entails, and the amount of hard work and hours that you need to put in. But somehow he wasn't successful, and I still followed that path. And I think I was in the 8th standard when I really decided that this is what I want to do. And then as I got into medical school, neurology continued to fascinate me more than any other specialty. And then I'm someone who likes to do stuff with my hands. So the combination of surgery and neurology brought together the field of neurosurgery, which I thought would be an excellent profession or a vocation to pursue. And a lot of the times when I think back, and still a lot of people ask me, what would you do if you weren't a neurosurgeon? And I don't have an answer. That speaks of my unidimensional personality.
But Mazda, I mean, while neurosurgery is in your genes, I'm sure if you were not a neurosurgeon, you would be an excellent writer.
I mean, but the thing is that I've also thought about that, but all my content of writing comes from what I do.
Yes.
And I'm horrible at writing fiction, so if I wasn't a neurosurgeon, I wouldn't have anything to write about.
Absolutely true. I mean, the passion that with which you follow neurosurgery is really commendable, and it's amazing how your father really taught you neurosurgery literally when you were young, and here you are, a very proud. I'm sure it's a very proud moment for your father to have
forever be indebted to him for showing me the way, and he continues to guide me in several aspects of the field. And early on in my career, there have been a couple of instances where in the middle of an operation, I have called him, telling him that I'm stuck. Can you give me some guidance? And he's provided brilliant advice. So it's
Excellent.
great to have someone who can hold your hand through this.
Yeah. So, Mazda, talking about brain tumors, I mean, you see brain tumors day in and out, and I also treat brain tumors. And the problems that our patients face, are in many ways they're so acute. I mean, the diagnosis of brain tumor, in most cases, as we see, it hits the patient suddenly. It's not something that happens gradually. So, do you have any thoughts about how do we sort of help our patients to detect if anything is wrong with their brain, or if they have a brain tumor early on? Because that's a question that keeps coming up. Doctor, could we have done something else which would have helped us to detect this dreadful disease early on? Are we late because we didn't pay attention? Do you have any thoughts on that?
Yes, I think it's a bolt from the blue for anybody who's diagnosed with a brain tumor. And I often think about myself that what would I do if I was, God forbid, faced with this diagnosis? I still don't think I have the tools to be able to deal with it, even though this is something that we deal with it on a daily basis. So yes, early detection in some sense is key. And oftentimes, I am a very strong proponent of getting an MRI done if you have the slightest of neurological dysfunction, starting with a simple headache. And I have gone hoarse telling the world that if you have a headache that doesn't go away in 1 or 2 weeks, get an MRI done. It's okay. 99% of the time that MRI will be negative. But still, I see, without exaggeration, at least 10 patients a year, most of them young adults, and all they have is a dull, aching headache. It doesn't have features of raised intracranial pressure, no vomiting, no double vision, no weakness of one side of the body, which are symptoms of significant neurological dysfunction. Obviously, if a tumor has specific cranial nerve involvement, it will present that way early on in the disease. But oftentimes, tumors in areas such as the ventricle or in the frontal lobe or even in the parietal lobe can go to a large extent without being significantly clinically present. So, if you have a dull, aching headache that's not going away in 2 weeks, you've tried some medication, you're not better, it's still bothering you, get an MRI done. It's changed the lives of those who we've been able to diagnose early. Similarly, in the elderly, if you have memory problems, if you have imbalance while walking, if you have something that doesn't feel right, don't attribute it to old age straight away. There is this tendency that, oh, grandpa's getting old, he might be talking a little off, he's forgetting things, it might be the beginning of Alzheimer's, oh, it looks like this could be Parkinson's. I've seen, again, similarly, at least 10 patients a year. And it may seem like a small number, but for that one patient, it's their life. And these patients have, all they have is a little bit of memory dysfunction. They're forgetting stuff that is slightly beyond the ordinary. And get an MRI done. That's as simple as possible. An MRI is available at every corner of the city now. Once you do an MRI, you've ruled out anything structural, then you can do whatever the hell you want. You can do Ayurveda, you can do homeopathy, you can do any form of alternative medicine also, it's fine. But rule out a structural pathology. Rule out something that we can reverse. Oftentimes, you may, even if you're smart and astute, you may pick up something that may be end stage to begin with. And we may not be able to win the battle. But several times, you may be able to pick up something early. And oftentimes, even seizures are missed as you might have been tired, that's why he behaved in a way. Or even sometimes doctors say, oh, this is just one seizure, we won't do a scan. If you have a single seizure, you have to get an MRI done.
So when you say seizure, you mean the convulsions, or what we
Convulsion, yes.
call fits, as patients would typically
yes,
understand as
or
fits. Yeah.
epilepsy or a fit. If any of those things happen, even once, I've seen till date, I continue to see people who don't get an MRI done at the first onset of a seizure or a fit. And they say, we'll see, we'll do it if it happens again. I'm still not able to understand. A lot of the times when we ask for an MRI, let's say for giddiness, for example, people have this tendency to think that doctors are just out there to fleece patients. They're out there to make money. They might be getting a cut from the MRI guys. That's why they're ordering so many investigations. And I don't even mind thinking, I don't even mind them thinking all of that as long as they get the damn MRI. Because, for example, let's say giddiness. Oftentimes, giddiness is the only symptom attributed to a vestibular schwannoma or a brain tumor that arises from the vestibular nerve or the balance nerve. And if you pick it up early when it's small, you can treat it. You don't even have to do surgery. You can treat it with one single dose of radiosurgery, which is forte if it's less than a couple of centimeters. So if we pick up these things early, we do have the ability to treat them well. Sometimes, for example, pituitary adenomas, there are tumors that compress the optic nerve, the eye nerve. I have seen so many people go to an ophthalmologist, which is what you would do if you have some visual dysfunction. And oftentimes they've been operated for a cataract and that hasn't gotten better. And then eventually they say, okay, let's get a scan done to see if something's going on. So
And this is very common. I mean, I see a lot of pituitary adenoma patients where they have had. I recently saw a patient who had visual disturbances, went to the ophthalmologist, did the cataract surgery. Then they said, oh, there is some retinal problem. So got some retinal laser done. And nobody thought of an MRI. And the patient had like a 3.5 centimeter tumor compressing the optic nerve.
yes,
There's this resistance. I mean, I'll give you my example. I had terrible migraines a few years earlier, and they're not getting better. I started getting worried. I got an MRI done, and it was normal, thankfully. And it gave me so much of relief.
Yes.
That I know that all the brain structures are there. I have a nice brain which is healthy, and then I just had to do some medications, and my migraine disappeared. My own father, in fact, this was when I was in my third year MBBS, I think 1999. He had just one episode of giddiness. He was traveling by train, he felt giddy, and he was otherwise healthy. So I took him to the hospital. We did a CT scan, and it showed a pituitary tumor. So we got the MRI done, and he was diagnosed with a pituitary adenoma. We got the surgery done and everything. So because we kept that threshold very low, that just one episode of giddiness in an otherwise healthy person, I think it really helped us to detect his tumor in time. But I completely agree with you. There's so much resistance from people, and especially with MRI. And it's
yes.
both ways. People say, oh, MRI takes so much time and it's so loud. And if you ask them for a CT scan for something else, they'll say, oh, CT scan has radiation, so we don't want to do it. How do you deal with these complaints from the patients, the resistance?
I think that you need to educate them. You need to eliminate fear from their system first. You need to tell them that if there is something, we will find it and we will be able to deal with it better rather than letting it be. And I think most of them understand. Some of them have very fixed ideologies. And again, like I'm saying, they may be right more often than us because the incidence of finding something may be less. But I would still insist and tell them that if this was someone in my family, I would not hesitate to get a scan done. Till the point doctors develop X-ray vision, we will still have to rely on these technologies to give us, because tumors unfortunately don't read textbooks, and a lot of the times people present with very, very atypical symptoms. Right now I had an old lady who had significant decline in her memory, and a lot of the neurologists, etc., kept treating her with medication, and finally an MRI was done which showed a lesion in the fornix of the brain. So I have hundreds of examples now over the past decade of me insisting on patients getting an MRI and we finding something. So I'm still sticking to my gun. Sometimes I fight with our neurologist, and the neurologist tells me that I'm really overdoing it by asking for imaging. But when I justify my point, sometimes we agree, sometimes we agree to disagree. But like I told you, science is an ambiguous thing. There's no definitive answer. You will base a lot of your treatment on your experience, and your intention at the end of the day is to try and help people to the best of the ability that you can. A lot of times people will, when you think that they don't need an MRI, they'll say, "नहीं, नहीं, MRI करा के दिखा दो," because we want to be sure that there's nothing. And that's also fine. The MRI is a safe procedure. It doesn't involve any radiation. There are really no side effects, except for some people feeling a little claustrophobic and uncomfortable in the machine. And now newer machines are coming out with technologies to deal with that as well. So I think by and large, it's a good strategy to sensitize people that if you have something that seems off in terms of symptoms, I always tell people that symptoms are a gift. Your body is telling you that something is going wrong. You are lucky that you've been told that something is going wrong. So please allow yourself to act on it rather than completely ignore it.
Yeah. Yeah, I also tell my patients that if you have pain and that pain has led you to a doctor, that is a gift because it's your body crying out for help. And if you ignore that pain or any other symptom and just take symptomatic treatment or painkillers or whatever, then you are actually not listening to your body. You are just ignoring the signal, which is such a critical signal that your body is saying, help me. And that's when you really need to go to the doctors and take help. So, as one of the common tumors you and I see are the gliomas. And the most dreaded one, of course, is the glioblastoma, which is the grade 4 brain tumor. And it is such a terrible disease because of the survival, which is very poor. So, if you diagnose, as you are aware, glioma, then patients have maybe a few months or 1 to 2 years to live. And in contrast to if you look at grade 1 glioma, then the survival is, of course, much, much better. How do you sort of deal with your glioblastoma patients or, high risk brain tumor patients?
So it's one of the most dreadful diseases, and it's really heartbreaking to be diagnosed with this condition. You won't believe it. I had a professor who I trained from in Toronto, and a couple of years after I finished my fellowship, when he was operating, he felt something off with one of his hands. He decided to hand over the operation to another senior colleague of his and went down and got a scan done, and he was diagnosed with a glioblastoma. And it may be heartbreaking for a surgeon who himself has treated this condition all his life to be diagnosed with that problem. So imagine what it is for a layperson who knows nothing about it to be told that you suddenly have 1 or 2 years to live. Unfortunately, stage 4 brain tumor is a disease in which over the last 3 to 4 decades, we've improved the survival by about 3 to 4 months. And even though newer advances are coming in, we really haven't made any sustainable breakthroughs. Yes, there are the oddball patients who live 3, 4, 5 years as well, and some even more. And there are the other end of the spectrum who don't even live a couple of months. I had a 16-year-old girl recently who had a high-grade, not a glioma, but a high-grade posterior fossa ependymoma, and was treated, but within 3 months, she had disseminated spread of the disease through the entire neuroaxis, brain and spine, and passed away. So these are very, very difficult conditions to treat. And sometimes I wonder whether if I had this problem, would I even opt for surgery, radiation, chemo, go through the whole motion, and then only wait for it to relapse again.
Yeah.
You have to be very sensitive to the family. You have to explain to them. You have to be their doctor all through the journey. As a surgeon, we tend to just operate and then say, "Hamara kaam ho gaya." Now you take treatment with the radiation doctor and the oncologist, and after 3 or 6 months, come back to us with a scan. But I personally try and handhold my patients all through their journey and remain connected with them, with the oncology team as well at every stage, to understand how they're progressing and to see what are the ways in which we can make their quality of life better. I think eventually you want to keep them comfortable. You don't want to
Yeah.
give them more suffering from the medical treatment just so that we're able to prolong their life. I think it's important that their quality of life is maintained through the time that they live. And then you have to get the entire family on board. You have to explain to them how to deal with this situation. You have to sensitize them. It's very difficult. And I have operated on, I have a couple of patients whom I have operated about 5 times for a recurrent glioblastoma. And I eventually have also then put my hands up and said, listen, let's not do this to him because we are just making him endlessly suffer.
Yeah.
So,
And sometimes the question is whether are you prolonging life or are you prolonging death in these situations? I remember only one patient, Mazda, only one patient who has survived more than 5 years. And his diagnosis was also initially was grade 3, and then other pathologists said it was grade 4, and he's doing well, but only one patient of glioblastoma. I remember when I was in Tata Hospital around 2001, 2002, was a new drug launch called temozolomide, which actually changed the way glioblastomas are treated, because earlier we didn't have a very good chemotherapy. We had radiation, and then we used to do that PCV chemotherapy, which was intravenous and was very toxic, and most patients would not tolerate it. And temozolomide was a complete game changer because it came as a capsule which patient had to take every day. It was so much easier, and it really helped the patient to prolong the survival. But even then, in patients who have had full surgery, full radiation, and then 6 months of chemotherapy, the survival is still around 14 months. So if you take treatment for 9 months, then you will get additional 5 to 6 months to survive, which is really, really sad in these patients. But the surgery plays a major role, whether it is a glioblastoma or other glial tumor. Surgery is the key. I mean, depending on how much tumor was the surgeon able to remove,
yes.
will really determine what is the survival of the patient. So, I mean, brain. We know that every millimeter of brain is critical. Every part of the brain has a critical function. How do you operate upon it? How do you take out a part of the brain and the patient is still okay?
Yeah, it's amazing, right? That you can remove up to a quarter of the brain and you still have someone who's walking and talking and moving his
Yeah.
hands and legs. But mind you, if you look deeply, they will never be the same person again. I have had, we love to show pre-op and post-op videos in our presentations, and we love to show patients smiling and lifting both their hands up and walking and doing everything. But when you really honestly ask the family, how is he doing? Oftentimes they say he's not what he used to be. So obviously we are messing with the circuitry, we are messing with white fiber tracks, which play very, very crucial roles in emotion, insight, judgment, memory, thinking, all of those. But uh, what to do? We have to attempt to resect as much tumor as is safely possible for patients to at least get a survival benefit from the operation. And the good news is that now with technology, we have the option of doing neuronavigation. We can map every single part of the brain. Preoperatively, we can plan the surgery with what we call as a functional MRI. We can put a patient in an MRI machine, ask them to move their hand, the hand area of the brain lights up, ask them to move their leg, the leg area of the brain lights up. We know exactly where important fibers are passing through in relation to the tumor. We know certain salient networks now. We are able to study connectomes of the brain now with the help of AI and advanced technology that is assisting us in trying to minimize uh, collateral damage that surgery can cause. And with those, we are tending to see better outcomes. Oftentimes, we even operate on patients awake. As you know, interestingly, that the brain per se doesn't feel any pain. It's only the outer coverings, the skin, the bone, the covering of the brain, the dura, all of these which can simply be anesthetized with a local anesthetic. And you can even knock on the brain and the patient's not going to feel any pain. But yet, the central regulating system is the pathway that relays all the connections that process brain. And that's the beauty of this magnificent organ, which we're still not able to completely understand. So we can operate on these patients awake. Let's say a patient has a tumor close to the speech area, and there is no way to check whether you're going to cause speech dysfunction, whether the tumor, the speech area has been displaced anteriorly, posteriorly. The functional MRI gives us some indication preoperatively, but if you operate on the patient awake, we can operate on them while they're talking to us. We have several tasks that we line up. We ask them to talk about their life. We check for repetition, we check for naming, we check for comprehension, we check for all the aspects of language while we are excising the tumor. And if at any time we realize that he's stuttering, we know that we reached the margin of safety, and then it might be prudent to stop so that we can at least preserve function completely and then allow for adjuvant treatment to act on it.
Yeah.
So
This is amazing technology when you think of it, that you are truly doing maximal safe resection, that you are functionally, and not just it's not just a picture, but it's almost like a video in front of you where the patient is doing tasks, and you are saying that, okay, if I cross this limit, I'm going to land up this patient in trouble. I recently, one of my cousins sent me this video of a musician
Yes.
who was getting operated playing guitar while he was having surgery, and he asked me, like, is this even possible? Is this fake video? What's happening here? So why don't you tell us about how you do it?
No, so these are, patients who have specific, let's say, tumors very close to the motor cortex. And let's say if they're a musician, or if they...
Motor cortex, you mean the area that controls the movement of the body?
Yeah, that controls the movement of the opposite hand and leg. And you don't even want any kind of subtle weakness. So if they're a professional, let's say they're a professional piano player or a professional drummer, you can get whatever they use or whatever is their main thing to we had a guy who used to complain, was diagnosed with a glioma in his motor cortex. He was a beautician, and when he was blow drying hair, his hand used to go into spasm while holding the dryer in one particular position, and that was very unusual for him. And we said, hey, let's do a scan, and we found glioma in the motor cortex. And then we got a mannequin into the operation theater and made him do that particular task while he was, and then we excised it safely to make sure that it doesn't get worse. So we get these patients. However, now with what we have, intraoperative neuromonitoring is also a tool where you can connect every single muscle of the body to a computer system where an electrophysiologist will tell you if the potentials of that muscle are going down when you're operating on the brain. So
when you say potential, what does that mean?
We look at motor evoked potentials and sensory evoked potentials. So if, let's say, I'm operating on the hand area, but the patient is not awake, there's no way to check his hand function. Some patients are not cooperative for an awake operation. Elderly patients, some patients who may not speak the language, some patients who may be very difficult to understand what you want to explain to them, because awake surgery requires a lot of preoperative counseling. You need to go through all these tasks. Everyone is not very cooperative for awake surgery. So those patients, you may not have the benefit of them being awake. So you connect them to what is called as a neuromonitoring system, where motor signals and sensory signals from the hand and leg will go to a computer. And if I'm operating on a certain part of the brain and the potentials of that area drop, then the neurophysiologist will tell me, hey, the left hand has become weak. So I will know I might need to change my strategy, go to another area, or wait for some time, see if the potentials are coming back. If they're not coming back, then I know then I might not want to proceed, because this might be the margin of safety for this particular patient. So we have these tools, but still we've not made the kind of advance that we should be making, because the brain is such a sensitive structure, and the outcome of a tumor really depends on two things: what pathology it is, whether it's high grade or low grade, and its location. So real estate in the brain is very, very critical. So if it's, let's say in a slightly dispensable area, you can remove it with impunity. But if it's in a slightly more eloquent area, an area that we consider as very important, now we've reached a stage where we don't consider any part of the brain as not eloquent. but you can remove a large portion of the frontal lobe and still have a completely functional patient. You can remove a large portion of the temporal lobe and still have a completely functional patient. We know that. But we are now able to identify the slight dysfunction that comes with removing these large pieces of brain. But however, it does give them an added survival benefit. So we have to, it's a double-edged sword. You have to weigh the risk and benefit of what you are eventually giving quality of life to the patient. I had a patient with a large parietal glioma, GBM, who was an artist and a painter, and a spatial orientation and understanding art, etc., comes from that part of the brain. So while we excised this tumor and this patient was completely fine after surgery, they could not paint the same way that they did before the operation. So while the scan looks good, we've given them an excellent survival benefit, we've taken away their passion. So, while we have a lot of victories in the kind of work that we do, we also have to accept with humility that we are not always able to follow the do no harm oath that we've taken while we enter medicine, because some collateral damage is being done, but it comes at some alternative price that keeps the patient going in some way. So these are very difficult questions. These are philosophical questions. These are questions to which I don't think we will have answers, but because for every patient, their requirement is different. Their truth is different. When I worked in Christian Medical College, we used to have tumor patients with large, giant tumors, giant vestibular schwannomas, and we did a study. And even though sometimes they had a facial palsy, which comes when you remove these large tumors because the tumor is completely stuck to the facial nerve, they were really not bothered by it because their imbalance went away. They could go back to their livelihood. They could earn their living even if they had a facial paralysis. Whereas if you look at people in the West, sometimes even with a subtle facial paralysis, they feel that their world has come to an end. So again, every single case that we do, in my opinion, has no generalization. Because what that patient feels and experiences is completely different from what anybody else will. So while we use these generalizations, we use studies, we use systemic analysis, we use all these reviews that we see to understand outcomes, I believe you impact positively or negatively every patient in a very different way.
Yeah.
So we have to continue to try and do the best we can.
Yeah. And as you said, we have to really look into every patient's story. And I also get patients in the clinic, and sometimes you wonder, what are they thinking about? I mean, I have had patients whom you give a particular advice, and then they go and do something else, and you wonder what's happening here. I had a patient with lung cancer, which was potentially curable. We advised them a certain therapy, and they said, no, I don't want to take this therapy. And we were trying to convince him that, this will be life-saving. And his point was, I have lived my life. And I don't want, for number one, to experience any side effects. Number two, my wife is elderly. And we just want to spend time together. I don't want me to feel the side effects and then her to keep nursing me for that side effect. We are just going to enjoy and see what happens. And while it's difficult for us to relate to it, but it's critical that we connect with them, we offer all the advice that we have, and then it is for the patient, it is their right to decide what they want and what their truth is, which may not be our truth, and
Correct.
We have to live with it.
Oftentimes, I think it's a good exercise. I often ask myself that what would I do if I had this? So, example, if I asked you, God forbid, if you were diagnosed with a high-grade brain tumor, what would you do? Have you ever thought about it?
This question comes to many patients ask this question, doctor, if it was you, what would you do? Or if it was your father, what would you do?
Yeah.
And I have developed a perfect way to deflect that question. I said, but you know what? It's not me. It's not my father. You have to decide. And that's one way of me deflecting that question.
But if you were to really introspect,
if I really introspect, I'm not sure, Mazda. Because while I'm so entrenched into modern medicine, I'm so entrenched into evidence-based practice. When I face a medical, serious, life-threatening medical issue, it will really depend on what's happening with me at that point. What am I thinking? What am I feeling? What life stage I am in? What does my partner want from me, and what do I want for him? So it really will vary. And over a period of years, as we gain experience, I think I have reached that point where I realized that modern medicine is not about just evidence-based medicine. Modern medicine is using that evidence-based medicine to enhance our life, and each person's life is very different, and the way you would enhance it is also going to be very different. We will have all the guidelines in the world, and which we should use, because that is the foundation of modern medicine that will really enhance the care that we offer. But every patient will experience. So if I were to diagnose with, for example, a GBM, if you ask me now, I'm most likely to go through the entire course of the treatment, because I'm still young, I have some life left in me. I want to experience life. I want to spend time with my family, my nieces, my partner, my mother. But if this happens to me, say 20 years down the line, I don't know. I don't know. I really don't know what I will do.
Yeah. These are difficult questions to answer. I agree.
Yeah. Yeah, and while we spoke extensively about glioblastoma, the other brain tumor which you and I see very often is metastatic brain tumors, and that's
Yes.
another, such a complex disease to manage. We have lung cancers, breast cancers, prostate cancers, spreading to brain. And while few years or a decade ago, we saw much less number of patients with brain metastasis, because those patients died of the primary tumor itself. They were not alive to experience or go through this process of the cancer spreading to brain. Now, with so much has changed in terms of surgery, radiation, and chemotherapy, that these patients are actually surviving for a long time.
Yes.
And because they're surviving, the chances that the tumors will spread to brain is increasing. And then the eternal question of how do we treat these brain tumors? Do we do surgery? Do we do radiosurgery? Or, do we just do regular radiation? And my advice to them always is like, let's explore surgery first, if that's feasible. And if not, we can try and do radiosurgery if that's feasible, or regular radiotherapy. What's been your experience from metastatic brain tumors point of view?
So 50% of brain tumors are metastatic and 50% of brain tumors are primary. In that primary, half of them are malignant and half of them are benign, more or less. So we also get a lot of metastatic brain tumors. The decision to operate is broadly, simplistically put based on if it's a solitary met or if there's multiple mets. If there's multiple mets, surgery does not prove to be very helpful. But if it's a solitary met, or if it's one or two mets close to one another, yes, definitely give the option of surgery. Surgery allows for further molecular testing of the tumor and relieves pressure on the brain. So it serves both purposes. And then you can decide if you, after surgery, want to give radiation to the tumor bed or give whole brain radiation. Again, all of those are more technical questions to answer depending on the primary pathology and what is the overall prognosis of the problem. But in general, I like to be aggressive as far as treatment is concerned. And if the patient is on board and is willing to be equally aggressive and try and battle the disease together, then I would opt for surgery as an option if the tumor is in a location that can be removed safely without any neurological dysfunction.
Yeah. And in multiple brain tumors, Mazda, as you're aware, we are able to now do radiosurgery. So even if patient has 3-4 lesions, generally my threshold is 5. If there are 5 small lesions, less than 5 small lesions, then we can do radiosurgery. And the advantage of radiosurgery is that you are giving very less radiation to the surrounding normal brain. You're just targeting the tumor because it's very precise. Radiosurgery, as you're aware, is just a misnomer. It's very high dose radiation given to a very specific small tumor. But Mazda, the fascinating thing about technology, and radiation is all technology, right? Now we have the technology, and we have been using it here, of memory sparing radiotherapy. So The concern is when we have patients who has multiple brain metastases or even regular glioma patients where we are giving radiation to the brain, the radiation affects the memory function, hippocampal area where the memory function happens. Now we are able to build the radiation treatment in such a way that we are able to spare the memory function.
Yes, I
So the
know. That's
patient
excellent.
gets patient gets the benefit of radiation and does not have the major side effect of memory function. So
Yeah, that's,
it's
I know,
really
I've
been
read several
fascinating.
papers on that, and and that's good because we are making, progress in all fields of neuroscience. Anesthesia has improved, so the outcomes of surgery have improved. Surgical technique has improved. The gadgets that help surgery has improved, and obviously adjuvant treatment has improved as well. So while everything has improved, and definitely we've made some progress in grade 2 tumors, grade 3 tumors as far as the overall survival is concerned. But still, unfortunately, for grade 4 tumors, the real kind of benefit, I'm still hoping, I believe the answer will not come from surgery or radiation or chemotherapy. It will come from some form of targeted
Yeah.
therapy, and everybody's brain tumor is going to have a different targeted protocol to be able to address it based on their molecular analysis. So it's like everybody's glioblastoma will be like their fingerprint, and we will reach a stage where we cannot broadly say that, oh, this is the tumor, this is the protocol that you have to go through. And that probably will eventually be the final nail on the coffin for gliomas. I hope we get to see that
Yeah.
in our lifetime.
Yeah, I hope so. I mean, the way oncology treatments are changing in last 5 years itself,
Yes,
immunotherapy has literally become a mainstay of treatment for
correct.
many tumors. We have excellent molecular and genetic markers that we are analyzing now, and the tests available. Earlier, they were available only in the US. Now they're available in India also. And we are now customizing treatment for our lung cancer patient, the breast cancer patients, pancreatic tumors. I think brain tumors are still a bit of a struggle. The problem with glioblastoma patients is that for you to do any meaningful study, we just don't get the time. Unfortunately, they pass away even before
Yes.
that. But there are many new targeted therapies that are being tried, and we hope that we see some impact of that very soon. Let's see. At Maza, we spoke about what you and I are doing in brain tumors and for our brain patients. So, what do you think is the future? Where are we going with the treatment of malignant brain tumors?
I think the future does definitely look promising. Like you mentioned, we have the surgical techniques. The first of all, the preoperative planning has improved, the intraoperative work has improved, and the postoperative care has also improved. Now we have tumor treating fields which help glioblastomas live a little longer. I have a feeling that eventually it's going to be targeted therapy that will decide the final outcome of gliomas. We have certain vaccines, but yet the outcome of those is not, again, foolproof and across the spectrum. And now glioblastomas, like I said, will be treated individually couple of years later as opposed to just a blanket treatment given to them. And I think that will probably be the advancement with the in cooperation of AI. We may be able to understand the molecular typing of each tumor a little better, and hopefully that will try and solve the answer for these cases. I think that's probably
And I think the while pathology is improving in terms of understanding the tumors, the radiology is also improving. The
yes,
MRI now has become like when you and I started our training, the MRI used to be so basic.
correct.
And now you have this beautiful MRIs where the tracks are seen, the
Yes,
areas are so visible,
yes,
and you have so many different types of protocols available. And now you have MRI available in your OT and
yes,
you have neuro navigation. So I think the future is already here
correct.
and it's going to get better and better as we go along. So, Maza, I'm a big fan of your writing, and I kept saying throughout the podcast today. So, tell us a little bit about this fabulous blog that you run. Why did you start it? How do you do it? Every Sunday morning, My Sunday morning starts with Dr. Mazda Turel's message about today's blog. And I was like, my God, how do you do this?
So it was actually, I have to give credit to the editor of the Sunday Midday, who booted the idea of writing a health column, but not in the normal way that health columns were written. It wasn't a therapy to prescribe stuff for headache or back pain, or if you have back pain, do these 6 exercises. If you have headache, this is what you need to do, or this is how you diagnose, or this is the latest. She Tina's Nushian is her name. She suggested that we write stories of the experiences we've had with patients and taking different pathologies and narrating them in a story fashion. And at the same time, trying to educate the common man about how to identify certain symptoms related to certain pathologies and how to take responsibility of your health in your own hands. And I think to some extent, I felt that we've succeeded because recently I had a patient whose son called me saying that, listen, my dad is thoroughly confused and he's slipping in and out of a coma. And all he's saying is, take me to Mazda, because I've read every single article of his and I know what problem I have. It's something to do with bleeding in the brain, and he's going to be able to fix it. And they got a scan done, and rightly so, he had a subdural hematoma, and they got him, and we operated on him, and he's absolutely fine. So I feel that it is important for us to reach out to as many people to be able to at least make themselves aware of certain conditions. A lot of the times I meet people and they say, hey, listen, I read your column about this, I did this, and it really helped me. So even without directly coming to me for advice, they're able to identify their problem. A lot of the times people come to me saying that, hey, listen, we read this, just check me out and see if this is what I have or this is something else. So I think in a light-hearted way, in a simple way, without making it too scientific, without making it too technical, I think it's important to let people know about symptoms and signs. It's also important to give people an idea of what doctors go through. Oftentimes, if a patient has a complication or if a patient dies, relatives sometimes feel that nothing happens to the doctor. But, sorry, the doctor is also sometimes a miserable wreck. To see somebody who you operated upon day in and day out in the ICU, not recovering, not getting better, knowing that it's probably something that you've done, in some sense harmed a patient. For a doctor, it's not at all easy to fathom. And patients also need to understand that no doctor would intentionally do anything to cause a complication or anything to. So I like to give in my stories some kind of backstory, some kind of insight, some kind of thought process. What happens when a patient doesn't wake up after anesthesia? What happens when a patient is absolutely fine 3-4 days after surgery and then suddenly has a complication? What are the options? What happens if you have a bleed in the brain and the option is to either operate and allow the patient to continue life in a vegetative state or just let them pass peacefully? There are so many scenarios that we face on a day-to-day basis as far as brain and spine problems are concerned. And I think it's important to bring out various nuances to be able to show people the entire spectrum. Also, it's important to tell patients stories. There are some patients who've overcome so many battles and have become successful and have come back to living a completely normal life after going through 1, 2, 5 operations. So it's also important for people to know that, these guys are dealing with so much. Why are we really complaining about the triviality of our problems? So, it's important. I write basically to inspire people, to educate people, to give them perspective about certain things, to enhance their awareness, to describe the complexities and the simplicities of our profession. And a lot of the times, doctors who read my article also tell me that this is exactly what we go through, but we're unable to express it. So I really, for me, the writing is in some sense a joy. It allows me to introspect on my cases also. It allows me, while I'm writing about a certain discussion I've had with a patient, it allows me to think whether I could have bettered that discussion, and I try to do it the next time. I also tend to spend a little more time with patients than I used to, just asking them a little bit about their backstory, a little bit about their personal life, not only to get more content to write about, but they feel that this guy is not treating me like another number or another
Yeah.
patient or another someone who's coming to
They're
us.
not just a scan that you're going to operate upon, but they're a person whom you're going to help
Correct.
to
Correct.
get better.
So I think the writing does more for me than it does for the people reading it. But I'm glad we've formed a nice community that follows these on a regular basis. And hopefully someday we should be able to come out with a book that compiles.
Yes, that I was just going to ask you, when are you publishing it as a book?
Yeah, we've got a publisher. I just have to sit down and select the ones that might work best.
Fantastic. And you're also empowering people to take charge of their life. And that I
Right.
think is very, very important, because when, especially in healthcare, people feel so disempowered. They're like, I don't know what's happening. I have no idea. And when you talk about brain, they're like, really, obviously, it's confusing. So you are actually helping people to understand how the brain works and what are the problems that they could face, and that's just amazing. So we are going to put a link to your blog in our this podcast also, so people who are listening can then go and follow you and benefit from all the beautiful writing that you do.
That'll be lovely. Thank you.
So thank you very much, Dr. Mazda Turel, for joining us today. It was a wonderful chat, and I think I also benefited a lot from understanding how you, as a neurosurgeon, are thinking about people, about not just the scan, but about the person behind it, and the inspiring stories that you publish. It's just fantastic. So thank you very much for sharing your time, for talking about the brain tumors and the neurosurgery. It was wonderful having you over on the podcast.
It's my pleasure entirely, and I hope we're able to even make a little bit of a difference, because eventually a little adds up to a whole lot more. And if you're able to help a few people identify their problems early, get them treated early, give them the quality of life that they desire, and eventually, in the hope that someday cancer would become an extinct medical entity, that would be a dream come true.
Absolutely. Amen to that.
Cheers.
Thank you very much, and you have a lovely evening. Good night. Thank you for joining us today. I hope you find today's episode informative. Please feel free to ask your questions in the comment section, and we'll get back to you with the correct information. Please do like and subscribe to the channel, but more importantly, share this information with people you care about. Join me in this fight against cancer.